Welcome back to Logical Pharmacology. Today, we are walking through a high-yield Next-Gen NCLEX case study on ACE inhibitors. We'll move through 6 screens, focusing on clinical judgment and pathophysiology. Let's head to the bedside. Question 1. Our client is a 92-kilogram male with type 2 diabetes, stage 2 hypertension, and stage 3 chronic kidney disease, admitted for new-onset heart failure with reduced ejection fraction. The question: click to highlight the 3 findings that place the client at the highest risk for adverse effects from ACE inhibitor therapy. Type 2, diabetes, stage 2, hypertension, chronic kidney disease, heart failure, weight, 92 kilograms. The correct highlights are chronic kidney disease, heart failure, and type 2 diabetes. ACE inhibitors block angiotensin II, the hormone responsible for constricting the efferent arteriole to maintain glomerular filtration pressure. In a healthy patient, this is protective. In a client with stage 3 CKD, heart failure, and diabetes, it creates a perfect storm for acute renal insufficiency and hyperkalemia. Students often overlook type 2 diabetes here because they've been taught that ACE inhibitors are renal protective. While true in early-stage diabetes, NGN logic requires recognizing the renal fragile patient. Basically, in a patient with these 3 comorbidities, any drug ending in Pril should trigger an immediate reflexive check of their creatinine and potassium. Question 2. It is 8:30. Vitals are BP 152/94, heart rate 88. The provider orders lisinopril 10 mg PO daily and to monitor electrolytes. The question: for each finding, specify if it is an expected response, a contraindication, or a reason to withhold the medication. 1. Serum potassium 5.42. History of angioedema with enalapril 3. Blood pressure 152/94/4. Serum creatinine 1.9. Potassium 5.4 is a reason to withhold. ACE inhibitors cause potassium retention. Giving this to a hyperkalemic patient risks lethal arrhythmias. History of angioedema is a contraindication. The NCLEX tests if you know that angioedema is a class effect. If they reacted to enalapril, they will likely react to lisinopril. This isn't just a reason to withhold, it is a hard contraindication. If a patient has a history of angioedema from any ACE inhibitor, the nurse should anticipate an order for an ARB, a sartan, or a different class entirely. They can never go back to the Pril family. BP 152/94 is an expected response. This is why we are giving the drug. Creatinine 1.9, a reason to withhold. This indicates significant renal impairment. We must notify the HCP before potentially decreasing renal perfusion further. Question 3. 2 hours post-dose. The client reports a dry, hacking cough and says, "My lips feel slightly numb." The question: drag the 3 most likely hypotheses to the box, ranking them from highest priority to lowest priority. 1. Hyperkalemia. 2. Numb lips. 3. Dry cough. 4. Ineffective renal perfusion. The correct order: numb lips, hyperkalemia, dry cough. Starting April 2026, NCLEX may present more options than in previous formats, which means you have to have stronger critical thinking to identify the best or first action. NCLEX logic always prioritizes the ABCs. Lip numbness is an early warning sign of angioedema. It's an airway issue. Hyperkalemia, related to circulation, follows due to the risk of cardiac arrest. The dry cough is a common side effect due to bradykinin buildup. It's annoying, but it won't kill the patient today. Question 4. The EHR shows the client is currently prescribed lisinopril, atorvastatin, and a 20 milliequivalents potassium supplement, potassium chloride. The question: which nursing interventions are appropriate? Select all that apply. 1. Monitor for peaked T waves on telemetry. 2. Instruct the client to use a salt substitute. 3. Review the most recent BUN and creatinine levels. 4. Question the potassium chloride order with the healthcare provider. 5. Assess for a non-productive cough every 4 hours. Correct answers: 1, 3, 4, and 5 peaked T waves. Option 1 are the first sign of hyperkalemia. Option 2 is the trap. Salt substitutes are almost always potassium chloride. Using them with an ACE inhibitor is a recipe for toxicity. BUN/creatinine, option 3, must be monitored for renal failure. ACE inhibitors are potassium sparing. Giving a 20 milliequivalent supplement alongside a drug that already saves potassium is a medication error in the making. Look for hidden potassium wherever you see a link. Salt substitutes, potassium supplements, and potassium-sparing diuretics, example spironolactone, are the 3 tricks NCLEX plays to see if you can prevent a cardiac arrest. Question 5. Emergency update, 11:30. Lip and tongue swelling have progressed. Audible stridor is heard. SpO2 has dropped to 88%. The question, complete the sentence. The nurse should first drop down 1 because the client is most likely experiencing drop down 2. The answer is, the nurse should first administer PRN epinephrine IM because the client is experiencing angioedema. In an anaphylactic emergency, oxygen and positioning are common distractor traps. While usually helpful, oxygen cannot bypass a physically obstructed swollen airway, marked by audible stridor. Epinephrine is the only definitive treatment for angioedema. It acts as the physiological antagonist to the systemic vasodilation, causing the swelling. It rapidly induces vasoconstriction, to reduce swelling, and bronchodilation, to open the lower airways. While diphenhydramine, Benadryl, is often used, it is too slow to reverse an active crisis. Never choose positioning or oral medications when the patient has a mechanical airway obstruction. If the airway is closing, you stop the process with epinephrine before you worry about the supplemental O2 or the bed angle. The nurse evaluates the client's response 3 hours after the emergency interventions were implemented. Click to highlight the 3 assessment findings that indicate the interventions were effective. Progress notes for day 1, 1400. Client is alert and oriented. Respiratory rate is 18 per minute. Breath sounds are clear to auscultation. Oxygen saturation is 96% on 2 liters per minute oxygen via nasal cannula. Client is resting quietly in semi-Fowler's position. Client denies further throat tightness. The indicators of success are respiratory rate of 18, clear breath sounds, and SpO2 of 96. While being alert is good, we are evaluating the specific problem, respiratory failure from angioedema. Therefore, clear breath sounds and SpO2 of 96% are the target outcomes that prove the epinephrine worked. When evaluating, always ask, what was the specific killer in the previous screen? If the killer was an airway block, the victory is a clear airway. Alright, that is the logic of ACE inhibitors. Remember, check the potassium, watch the kidneys, and always protect the airway. See you in the next case study. I'm on a mission to complete a 100 case studies marathon to help you master NGN logic. Subscribe to join the marathon and support the channel. Let's get you licensed.